Thank you, Dr. Brogy. It's a true honor and a privilege for me to join you, to be invited to be here. I first came to Milano with my wife in 1964, and it remains a beautiful and wonderful city, and thank you for having me. I put up an image here, which is a drawing, probably not unlike the image that Dr. Chiari saw when he made his very important remarks about this subject in 1891. He encountered at autopsy, he was a pathologist from Vienna, 14 patients who had died, many of them, perhaps the majority of them, children, who had died with hydrocephalus. He regarded the herniation of the cerebellar tonsils through the foramen magnum as a secondary effect of hydrocephalus. He referred to the term cerebellar coning. And that's how the condition came to public attention. Through the years, it was modified, subtypes were added. Chiari himself did see several cases of tonsillar herniation in association with myelodysplasia, myelomeningocele. But not all the things that are called Chiari probably would have met with his approval. The great advance came with the advent of magnetic resonance imaging, because for the first time one could actually see the herniation without having to visualize it at surgery. The only other ways of looking at tonsillar herniation before MRI were indirect studies such as myelography with or without combination of CT. But here it is, an opportunity to see the posterior fossa, the tissues that exist within it, and the spinal cord as well. And shortly after the advent of MRI, the definition of the condition was turned over to neuroradiologists, and we live with that definition to the very moment. The definition you've all heard many times through the meeting of herniation 5 millimeters or more below the posterior rim of the foramen magnum, but then sort of quantifiable variations have been added. If it's herniated a little bit, people will refer to it possibly as Chiari 0 or minimal tonsillar herniation. And there's been great focus on the extent of herniation as sort of the driving force in understanding these conditions. Dr. Nishikawa, who has worked with us, has demonstrated in age and sex matched patients that the cerebellar tonsils are always within the skull from 3 to 4 millimeters. Now, in the 1980s, various attempts were made to better understand this condition, and morphometric analyses were made of the posterior fossa and the tissues within it, measuring different elements. And the first major contribution on the small posterior fossa was made by Dr. Nishikawa in Osaka. And he established that in the classical Chiari malformation, the posterior fossa is hypoplastic. And this immediately led to a pathogenetic theory that there was a mismatch of volume of the posterior fossa, which was small, and the normal volume of the cerebellar contents, which were normal, thus forcing the tissues inferiorly, tonsils, through the foramen magnum, and in some cases allowing the superior cerebellum to herniate upward through the tentorial notch. A few years later, we sort of added to this, although the full credit of the small posterior fossa belongs to others, and we were able to identify volume, which had not been previously measured. I noticed driving through the streets of Milano, there are several streets named Cavalieri. I don't know whether there's any connection, but that's the methodology we use for measuring volume. And we also added the first studies that suggested that Chiari 1 malformation, the classical type, the hypoplastic posterior fossa type, was associated with transmission, primarily recessive transmission. In some cases, in some families, dominant transmission with skipping of generations. And so, with the help of many people, and I just referred to 2 studies, but there have been contributions from many fronts, our understanding of Chiari-1, classical Chiari-1 at the present time, is that it's some form of a genetic disorder that involves the paraxial mesoderm, the segmentation of the mesoderm, which includes soft tissues and osseous structures. Our understanding at the present time is that in classical Chiari, there's underdevelopment of the occipital enchondrium. There is an associated reduction of the volume of the posterior cranial fossa. This contributes to downward displacement of the cerebellar tonsils, varying degrees of obstruction of CSF flow between the cranial and spinal compartments owing to impaction of the foramen magnum, and a variable incidence of what is truly called a non-communicating type of syringomyelia. Non-communicating in the sense that the fourth ventricle does not communicate with the syrinx in most cases. That's our understanding of the classical type. And of course, with the small posterior fossa, the hypoplastic posterior fossa, the operation of suboccipital craniectomy, laminectomy, duroplasty, and the various modifications that surgeons use have been applied to primarily all types of Chiari malformations. Now, what I'd like to do is spend some time discussing a classification of Chiari malformations based on what are the different causes of cerebellar tonsil herniation. And we've had the opportunity for this study to investigate a very large database of over 3,000 patients and to apply morphometric analytic standards to the posterior fossa and to the tissues within it. I will just say that there are subtypes of Chiari that are well known to the members of this audience. Pictures that look very much like this. This may be what Dr. Chiari would have seen in his 14 autopsy cases if he had the advantage of MRI. Hydrocephalus, impaction of the foramen magnum, tonsillar herniation, in this case a syrinx, which may have alluded to Dr. Chiari. And this is, in this particular case, a normal posterior cranial fossa, volumetrically and in terms of its osseous measurements. So in a case like this, one could say with some degree of certainty that the cause of the tonsillar herniation was downward displacement from raised intracranial pressure and hydrocephalus. And probably many of you in the audience have seen, after effective treatment of hydrocephalus, either through third ventriculostomy or old-fashioned ventricular peritoneal shunts, a reduction in ventricular size, an ascent of the cerebellar tonsils, and in some cases a reduction or disappearance of syringomyelia. So this is different. This is a different kind of Chiari because it appears to be acquired and the posterior cranial fossa is not hypoplastic. Now, many of you, the room is filled with people in pediatric specialties, pediatric surgery included, but it is well known to pediatric neurosurgeons that in a significant number of children with prolonged lumboperitoneal shunting over months and years, there is a significant incidence of what is called, by measurements alone, more than 5 millimeters, a Chiari. We wanted to investigate whether this was truly a Chiari in terms of hypoplasia of the posterior fossa, or whether this was just a pure secondary effect of a pressure gradient that tended to pull the cerebellar contents into the spinal canal owing to a negative pressure gradient in the spinal canal. So this was one of the subjects we wanted to look at. Also, I think Dr. Bolognese has told you about our work fairly recently published, describing an association of Chiari with a completely foreign type of disorder, a connective tissue disorder that is associated with cranial settling, where the head comes down on the neck, a little bit like a pumpkin on a stick when the patient assumes an upright position, producing Chiari malformation, and often all the symptoms that we've come to identify as being Chiari-like symptomatology. I'll just show you what this Ehlers-Danlos syndrome looks like if you haven't seen it. It's a hypermobility of the joints of the body. They can be limited to small joints. They can involve large joints. Many of these patients can simply pop out their joints at will. It's quite dramatic. And usually this is of little or no consequence. If the patient injures one of these weak joints, then it can be problematic because the joint can be permanently dislocated. There's a way to measure this, and Dr. Bolognese spoke to it yesterday. I won't repeat it, but we measure small joint mobility to get a sense of the degree of the condition. It's associated with wound healing problems. It's associated with large joint dislocations, mitral valve prolapse, and the rest. Now, one of the early studies that we did was to apply morphometrics to this condition, and we found that the average tonsil herniation, I believe the number of patients we reported in the Journal of Neurosurgery was slightly more than 350 cases, but the measurements showed that the posterior cranial fossa in terms of size of the occipital bones and volume was normal. We found that all the other measurements of brainstem structures in general were normal. And yet we had tonsillar herniation. The only variable that we were able to define was this hypermobility of the joints that hold the head on the neck associated with cranial settling. So indeed this turned out to be yet another type of Chiari malformation as currently defined. It's really a different type of cerebellar tonsil herniation, but since we are locked in to the definition of Chiari being 5 millimeters or more, it will be seen by a radiologist and called a Chiari. Here's just an example of the significant effects of cranial settling in a patient who was bedridden for 5 years with brainstem symptomatology, postural orthostatic tachycardia syndrome, orthostatic hypotension when the patient would get from a bed to an upright position, blood pressure would drop, the patient would have syncope, and profound difficulties with breathing and swallowing in the upright position. Most MRIs are done in the supine position, and this patient had what looks like a normal scan. The tonsils are not herniated, and all the measurements here are normal, as best we can determine it. The only thing that was evident here, and in the beginning we did not appreciate it, is a significant pannus deformity around the odontoid. We have since come to regard the pannus as a sine qua non of micromovement. When there is micromovement of the odontoid, that may not be, and usually is not, demonstrated by flexion extension x-rays. It's a sign of micromovement. The patient goes from a supine to a sitting position, and look what happens. There's significant herniation of the cerebellar tonsils. There is compression of the brainstem from behind forward, so that there is some degree of basilar impression. And the angles of the clivus to the dens change. That's a lot of flexibility. This patient could survive and prosper in a sedentary life, lying and resting in a chair, but as soon as she stood up, She became symptomatic and spent years of her life basically in a sedentary position. As Dr. Bolognese mentioned, when her head was lifted off her neck, she immediately felt well in the upright position. So some of these clues began to develop. Dr. Bolognese told you how we measure this with invasive cervical traction and try to find a position which is optimal. When we find a position that is optimal, supine position, upright, shows cranial settling, posterior gliding of the occipital condyles. In traction, we can reduce that, and if it is consistent with a elimination of the major symptoms, we can replicate that at the time of surgery. And what we do, this is not just a fusion, this is a fusion in extraction. The patient's head is put up and held up by this type of instrumentation. We often use osseous grafts as well. So that has occupied quite a bit of our time and attention. By far the most controversial, the most bitterly debated, the most skepticism-inducing work that we've done has been in the area of the tethered cord syndrome. This work will be online probably within a few weeks and published in print form a few months after that. But I'll tell you what captured our attention about this condition. Dr. Bolognese mentioned that through the years, approximately 50% of the cases that are referred to us are referred for failed Chiari operations. And we've taken a certain amount of pride in that because it is always a challenge to try to repeat or to repair prior surgery. And sometimes, most of the times, the patients that came in with failed Chiari operations, the explanation was clear. Craniectomy decompression was too small, it was too big, there was a complication such as a pseudomeningocele formation. But there was a subset of patients who had what appeared to be normal decompression surgery, well conceived, and often with improvement clinically for 3 or 4 months after surgery. But then, after that time, the symptoms started to return and become worse to a point where the patient was actually sicker than he or she had been prior to the decompression. And it didn't seem to make sense that here was inadequate decompression. At one point, there was a cisterna magna here. Now, after surgery, the tonsil has come down even more than it did before. And we noticed another thing. It appeared as if the brainstem itself started off a little long, and that after the decompression, not only did the tonsillar herniation increase, but the length of the brainstem appeared to be even more elongated. We didn't understand this. For many years we noted it, and our treatment was to do a posterior fossa revision and try to give more space of pedipalpoplasty and so forth. But our success with this group of patients in the final analysis was really no better than the first try with the operation. And so we made pains to try to understand this as best we could. Normal decompression with descent of the tonsils rather than descent of the tonsils. We found belatedly that when we examined these patients from top to bottom, many of them would report symptoms that were consistent with what we understood to be the general symptoms of tethered cord syndrome. Most of these patients did not have a tethered cord as it would be generally understood today. The conus was not down below L2-3. One couldn't see a thick, short, fatty filum terminalis. But they had a high incidence of the symptoms that are consistent with tethered cord syndrome. What's more, when we put them to proof with heel walking, traction of the truncal traction, they got worse. Symptoms, back pain, headaches got worse. Neck pain got worse. And when they did toe walking, it seemed to relieve these symptoms. these tests are very general tests, but they are sometimes used in determining tightness of the final terminality. And the high incidence of these patients had the things that we associate with tethered cord syndrome, even though the conus was in the normal position. High incidence of neurogenic bladder. Many of them had terminal thoracic syrinxes. You've all seen them, the little cavities that are just in the thoracic or lower thoracic segments. Many of them had no syrinx above, but they had this terminal syrinx. And in addition, there was a high incidence of scoliosis. I'll just review the classical tethered cord syndrome as it is generally known, although people have different criteria. But the symptoms and signs of tethered cord syndrome include all of the things you see up here. Urinary dysfunction, often with incontinence, urinary urgency, sensory loss in the bladder, incomplete emptying of the bladder, bowel incontinence, low back pain, foot and leg pain of various types, numbness on the soles of the feet, gait disturbances, quite variable, weakness in the legs, atrophy of the calf muscles, loss of DTRs, reduced deep tendon reflexes in the lower extremities, thoracolumbar scoliosis. Children sometimes present with equino varus or valgus deformities of the foot. And there may be an incidence of spinal dysraphism here. The radiographic criteria, like the radiographic criteria for Chiari, are really locked in. If you don't have a herniation greater than 3 to 5 millimeters, it's not a Chiari. And if you don't have a low-lying conus below the L2-3 interspace, you don't have a tethered cord, radiographically speaking. And usually one sees with these low-lying conuses that the phylum is thick, it's short. And sometimes you can pick up a signal for fat. One of the topics that has challenged the pediatric neurosurgery community, and I know it's a great controversy, but also great concern, is the so-called syndrome of occult tethered cord syndrome. That is to say, the syndrome is there, but the radiographic supporting data are not. In general, the symptoms of tethered cord syndrome, occult tethered cord syndrome, are the same as those for classical tethered cord syndrome. The radiographic criteria, however, are different. With occult tethered cord syndrome, the conus medullaris is above the lower end plate of L2-3. And sometimes it's up at L1. It's not below the 2-3 interspace. And there's a variable incidence of a thick, fatty phylum. In some cases, you can't see the phylum. So this is a disconnect, a syndrome that exists, but criteria that do not conform to our common understanding. In looking at this problem, we extended the criteria for occult tethered cord syndrome somewhat. The patients had to have all the classical symptoms and signs. The patients had a neurogenic bladder confirmed by urodynamic testing. They had positive toe walking, heel walking, pelvic traction tests, terminal syrinx, spinal dysraphism, and dorsal position of the phylum terminale on the prone or vertical upright imaging. And this is a group of patients that we started to look at. And we had the advantage of Dr. Nishikawa applying both retrospectively and in new patients prospectively measurements that are now done routinely on all of our patients. We measure the position of the conus medullaris from the upper end plate of L1. We get a measurement there. We get measurements of the posterior fossa. We get measurements of the structures that are within the posterior fossa. And what we quickly found in this group of patients, we are going to report, and I'll talk extensively this afternoon about the surgical outcome of 315, I believe it is, patients that have undergone section of the phylum terminale. But what we found here in comparing patients with classical Chiari and those who had Chiari associated with the tethered cord syndrome is that In classical Chiari, the measurements of the posterior fossa, the volume of the posterior fossa, are all small. We found none of that in the patients who had occult and classical tethered cord syndrome. In those cases, posterior fossa put to proof with morphometrics, not just the eyeball saying it looks small, it looks normal. These were very detailed measurements. In the mean, there were a few exceptions on the end of the bell-shaped curve, but the mean was there were normal measurements of the posterior cranial fossa and normal measurements of the volume. But what we did find is one abnormality, the osseous measurements. The foramen magnum was large, whereas in Chiari 1, the foramen magnum is small. And in addition, we found evidence of elongation of the brainstem, and we found downward displacement of the fourth ventricle and the medulla. This would be a typical picture of a patient prior to section 5 terminale. A very long brainstem. The upper mean is about 53 millimeters. This is more than a centimeter elongation. This one happened to have significant tonsillar descent. All the measurements here were normal, and the abnormalities were consistent with an enlarged foramen magnum, elongation of the brainstem, and downward displacement of the brainstem. We're going to talk about this afternoon, and I'm just going to introduce this subject because the subject this morning is not a tethered cord, but we have to, we'll review this afternoon. The symptoms that these patients have are usually dominated by the symptoms of Chiari. They present often with headache, posterior neck pain, dizziness, and other Chiari symptoms. The tethered cord symptoms are subtle and sometimes are passed off as being unimportant given the severity of the headache. We went years before we picked up on this, and it required that we would ask or do examinations to determine that, yes, the patients did have these symptoms, and tests were applied. Dr. Valentini, to whom I'm very indebted in many ways, pointed out when she visited us in New York that she had a number of children, as did we, who had presented with various problems of attention deficit hyperactivity disorders, the types of things that are rather soft diagnoses of a child neurologist, and that she had had the same experience that we did in those who had been untethered, that often the problems of their ADHD would improve. But we'll talk about that this afternoon. And I will point out only one thing here, that in this group of patients we'll be discussing, the vast majority of them had occult tethered cord and not classical, although we had that group of patients mixed in. The surgical outcome will be presented, and I think that our limitation here is the limitation of any new study, and that is the mean follow-up, which is short. Just to give you a hint, as I said, with this problem we would see again and again of tonsillar descent after a classically performed, well-performed posterior fossa decompression. This patient actually had a plate put on as a second procedure to sort of support the cerebellum. In this case, 10 years ago, we would have tried to do something more here. This patient had a tethered cord, and just for the occult, for the purposes of the operation, after untethering, there was a favorable response. We now sometimes do this as virgin operations when there is coexisting Chiari, normal posterior cranial fossa volume and size. So it sort of, from our standpoint, removes some of the impetus for doing a decompression. And if there is coexisting tethered cord, we will do it. And we've had cases that have avoided posterior fossa surgery. I'll go into these cases later. What I want to really just focus on for the remaining part of this presentation, and it won't be too long, are not so much reclassification of Chiari, but a better understanding of the different mechanisms of cerebellar tonsil herniation, which today wind up being called Chiari. But what we're really interested in is what makes the cerebellar tonsils descend through the foramen magnum into the upper cervical canal. So we selected out of our database patients who had at least tonsillar herniation of 5 millimeters or more. They all needed to have had complete 2D CT with 3D reconstructions and MRI scans of the head and cervical spine. We excluded the many patients that we see with past surgical treatment. These were all new patients without prior surgical treatment. And none of the patients were younger than 15 years or older than 69 years to minimize age-related changes in the skull and brain. So we were simply looking at a group of patients from 15 to 69, no prior surgery, who had tonsillar herniation, all comers, whatever the conditions were. And as it turned out, we came up with 352 patients, and they had the following criteria clinically. These were patients, largest number were patients with Chiari and no identifiable cofactors. This turned out to be a Chiari. They didn't have other problems like connective tissue disorders or hydrocephalus or things of that sort. The second largest group, and this is, as Dr. Bolognese mentioned, simply a referral pattern because so many of these patients come to us, were patients who had hereditary disorders of connective tissue. A third group were patients with classical tethered cord syndrome. And in this study, these were only patients in whom the conus was positioned at or below the L2-3 interspace. And the phylum was short, and it was thick, and in most cases, there was a signal for fatty infiltration. We had 30 patients with varying types of intracranial mass lesions, Chiari, but associated intracranial mass lesions. And we included hydrocephalus as a intracranial mass lesion in neurotypes, as we'll point out. We had 28 patients who came in with Chiari and a history of prolonged lumboperitoneal shunting, and as best we could determine it, a functioning lumboperitoneal shunt. We had 5 patients with classical craniosynostosis in this group, a couple of APERTs, a couple of Cruzons, and 1 oxycephaly. And then there were miscellaneous patients. And then, in this day and age, we were fortunate to find 11 patients with true Chiari 2, who had not had surgery on the posterior cranial fossa. And in our country, Chiari 2 is a very rare condition because most of the pregnancies with this condition are identified, and in most cases the pregnancy is terminated. But we came up with 11 patients with Chiari 2 who had a surgically repaired myelomeningocele. And the morphometric measurements, I won't go into them, they're very detailed, but we looked at just about every kind of measurement of the occipital enchondrium that we could, measurements of the foramen magnum as well. And I'm going to summarize this data, but I'm showing it just to give you some idea of how extensive it was. One of the treasures of this study was the development of age and sex-matched control measurements of normalcy, of occipital bone size, of volume analysis, of other cranial structures. In classical Chiari 1, that first group of patients, there were 388 patients with no associated disorders. The posterior cranial fossa was small. The foramen magnum was small. The posterior cranial fossa volume was small. In 225 patients with hereditary disorders of connective tissue, the size and volume of the posterior cranial fossa were normal. In patients, 55 patients with classical tethered cord syndrome, the foramen magnum was large, but the posterior cranial fossa size and volume were normal. In patients with intracranial mass lesions, everything was normal. The posterior cranial fossa was normal, size, volume, foramen magnum was normal. In patients with prolonged lumboperitoneal shunting, everything was normal. Size of the posterior cranial fossa, volume, foramen magnum, size. In patients with intracranial mass lesions, same, everything was normal. And in patients with Chiari-2, the posterior cranial fossa was small, the volume was small, foramen magnum was large. This information conforms with what has been known about this condition for more than half a century. Now, what was interesting is that looking at the foramen magnum size and shape, this is the normal sutures of the foramen magnum and synchondroses that are present, in this case, in an 8-month-old child. And when we grow up, this is what a normal foramen magnum looks like. It has a slightly oval shape to it. In patients with simple Chiari-1, that is, no associated disorders, the foramen magnum is small. In patients with craniosynostosis, to our way of thinking, or at least to our eyes, we could not distinguish the two. They looked exactly the same. The only difference that we found, and it's a subject for discussion on another day, is that the smallness of the posterior cranial fossa in classical Chiari-1 usually involves the inferior half of the posterior cranial fossa. It's almost like a localized craniosynostosis of the inferior half and the foraminal outlet. Above Twining's line, the volume of the posterior cranial fossa in a typical patient with Chiari-1, classical Chiari-1, is normal or slightly enlarged, and of course the rest of the head is normal. In patients with craniosynostosis, the entire posterior cranial fossa is small, and usually supratentorially it is small too. Here's a tethered cord syndrome though. Some of our biggest foraminal openings were in the cold tethered cord. And we also saw this in Chiari-2, although we had just a handful of cases. In these instances, the foramen magnum tends not to be so oval as we see in other conditions. It tends to be rounder. So to summarize this information, in the 750 cases or so, we found that in simple Chiari-1, classical, if you will, Chiari-1, where there are no identifiable associated conditions, occipital bone size is small, posterior cranial fossa volume is small, and foramen magnum is small. In patients with craniosynostosis, albeit we have a small handful of cases, we found exactly the same thing. Occipital bone size small, posterior cranial fossa small, foramen magnum small. In patients with Chiari and tethered cord syndrome, in this study, it was all classical, not occult. The occipital bone size is normal, posterior cranial fossa is normal, but the foramen magnum is large, a very distinguishing radiographic finding. In patients with Chiari-2, and again this was a small number of cases, we had a large foramen magnum, just as we did with tethered cord, but in this instance, the size and volume of the posterior cranial fossa was small. We have no explanations for it. We don't really even have any theories about it. And what my intention today is simply to provide you with the data. And it would be food for thought about many things. With cranial settling associated with connective tissue disorders, everything is normal. Size, volume of the posterior fossa, foramen magnum. In patients with intracranial mass lesions, hydrocephalus, we had 5 or 6 posterior fossa cysts. We had a vena galen, we had a big AVM of the cerebellum, we had 1 subdural, supratentorial, and so forth. The TRA1 was associated with no abnormalities of occipital bone size, posterior cranial fossa volume, or foramen magnum diameter. And the same was true with lumboperineal shunt. Everything was normal. So, in a tentative way, in our attempt to better understand the different causes, the mechanisms of cerebellar tonsil herniation, we are delicately moving into 5 different potential mechanisms for downward descent of the cerebellum. The one we probably all understand the best at this time is cranial constriction, whether it occurs in the classical TRA, which tends to be a lower posterior cranial fossa constriction, small foramen magnum, whether it's more generic, generalized craniosynostosis. We see it with achondroplasia. Some of our miscellaneous cases, I think we had 5 patients with achondroplasia. We've had some with acromegaly. We've had some with Paget's disease. What they share in common is cranial constriction. So it's possible that the primary mechanism of cerebellar tonsil herniation in patients with cranial constriction is simply that. It's a disproportion of the compartment size and the tissue within it. That's one possibility. The second involves the subject of spinal cord tethering. Our data are leading us to the conclusion that the one variable, elongation of the brainstem, downward displacement of the brainstem, in association with a totally normal posterior cranial fossa, is suggestive evidence that there is downward traction. And I'll go into that much more detail this afternoon. The cranial settling, I think everybody in the room could see it. When you have an upright MRI, the head comes down on the neck, and the tonsils can descend through the foramen magnum. Now, there are other conditions that can also produce herniation of the cerebellar tonsils, positionally related. That includes the same general idea of destabilizing the joints that hold the head on the neck. We've seen about 60 to 70 patients who have had severe whiplash injuries where there's been destabilization of the joints that hold the head on the neck, with patients who have not had classical subluxations demonstrable by flexion extension MRI, but they come in with a diagnosis of TRA, and it turns out that the precipitating factor was really trauma. I should also say that although I showed you a patient with Ehlers-Danlos that was normal in the supine, many of them are not normal in supine. They do have TRA. That's how they come to us. But they get even worse when they go up. I tried to show you one from normalcy to C1 herniation. But many of them on upright MRI go from C1 down to C2. Then there's the subject of intracranial hypertension. This is what Dr. Chiari himself probably first saw at autopsy. A increased pressure, which he referred to as cerebellar coning. And in our studies, as I mentioned, we've had posterior cranial fossa cysts. Of course, tumors do it. And every pediatric neurosurgeon that a child with a medulloblastoma or a large cystic astrocytoma will have tonsillar herniation, but it hasn't been looked at from the other side. That's a chiari. It's a tumor, and it's produced herniation. So the fact that there is compartmental pressure, mass effect, the skull isn't small, but there's still a disproportion of the tissues and the compartment. And subdural hematoma, we had a couple of cases of that. And we had one large pituitary adenoma that was also producing a tonsillar herniation in the absence of any abnormalities of posterior cranial fossa size and volume. So we come to the final one, which is the intraspinal hypotension. And from our data, one finds a normal posterior cranial fossa, tissues within it appear normal, but the tonsils are descended downward. And the one variable in patients with prolonged lumboperitoneal shunting is exactly that, lumboperitoneal shunting. And in many cases, simply ligating the shunt, removing the shunt, putting the shunt, transplanting it to a ventricular peritoneal shunt if it's necessary, will allow the cerebellar tonsils to go up. So we are going to be looking and focusing on this as time goes by. Because I think from the standpoint of physicians in the room, if the radiologist were to say Chiari-1, he's just telling you that the tonsils are herniated 5 millimeters or more. But Dr. Nishikawa is working on software which would make it possible for that radiologist to give you immediately on the dictated report size and volume of the posterior cranial fossa. And wouldn't it be useful to know this is a Chiari, small posterior cranial fossa, then hypoplasia is the presumed cause. And you could be comfortable in saying, well, all right, that's a Chiari, small posterior fossa. You don't have to do it with your eyeball. It's morphometrically proven. If the patient rises to the level symptomatically of requiring an operation, if it meets the indications for operation, then the proper operation is a posterior fossa decompression. On the other hand, if the radiologist says this is a Chiari-1 malformation, tonsil herniation, 5 millimeters or more, but posterior fossa volume and size are normal, that would then lead the doctor to examine other possibilities. Please correlate with clinical findings, might be the way the radiologist would present it. And then go back and say, you know, this patient did have a lumboperitoneal shunt 3 years ago. Maybe that's what's doing it. I know the posterior cranial fossa is normal, so this isn't really a classical Chiari. When you're looking at hydrocephalus, the question comes up, is hydrocephalus the cause of the Chiari? Or is the Chiari the cause of the hydrocephalus? Well, if the posterior cranial fossa volume and size are normal, it's more than likely that intracranial hypertension is producing tonsillar herniation. On the other hand, if the posterior fossa size and volume are small, it's probably more likely that the Chiari has obstructed CSF pathways and is producing the hydrocephalus. These are the kinds of things that I think would be helpful to physicians, to think of this condition not simply as Chiari, because there have been so many definitions and redefinitions, but we really come back to only one, which is the radiographic definition, that it sort of discourages us from looking at the cause or mechanism of cerebellar tonsillar herniation. And after all, in a treatment sense, that's what we want to treat. We want to treat the cause, the primary cause, rather than the effect of that cause. And I'm hopeful that this will be of some interest to you. And as time goes on, this is something that will help our discussions in trying to not lump everything into one category and then we all get confused about it, but try to segregate out different types of cerebellar tonsillar herniation as a guide to diagnosis and as a guide to treatment. Thank you for your patience.